In this video, we are going to discuss about diabetic ketoacidosis. So, diabetic ketoacidosis is a potentially life-threatening complication in people with diabetes mellitus. It happens predominantly in those with type 1 diabetes, but it can also occur in patients with type 2 diabetes under certain circumstances. So the diabetic ketoacidosis results due to shortage of insulin. In response, the body switches to burning of fatty acids, leading to production of acidic ketone bodies that cause most of the symptoms and complications. So it is defined as the presence of all three of the following. It is accompanied by hyperglycemia, that is glucose concentration more than 250 mg per deciliter, ketosis, and acidemia, that is pH is around less than 7.3. So this figure shows the hyperglycemic state, metabolic acidotic state, and the ketotic state. If all these three states arises in a patient, it will lead to diabetic ketoacidosis. So conditions where hyperglycemic state can arise are diabetes mellitus, hyperosmolar hyperglycemic state, impaired glucose tolerance, stress hyperglycemia. Conditions where metabolic acidotic state can arise are lactic acidosis, hyperchloremic acidosis, uremic acidosis, drug-induced acidosis, whereas the ketotic state can arise in case of ketotic hypoglycemia, alcoholic ketosis, and starvation ketosis. So what is the role of insulin? Insulin is required in our body for transport of glucose into muscle, adipose tissue, and in liver. Insulin also inhibits lipolysis. When there is absence of insulin in the body, there is glucose accumulation in the blood. So this increased glucose accumulation uses amino acids for gluconeogenesis. This ultimately leads to conversion of fatty acids into ketone bodies. So there are three basic ketone bodies in our body. They are acetone, acetoacetate, and beta hydroxybutyrate. So in this diagram, we can see a case of diabetic ketoacidosis when there is insufficient or absent insulin. So in the muscle cell, there is conversion of glucose into amino acid, and in the fat cell there is production of fatty acid and glycerol, and there is also increased glucagon in the blood. So there is ultimately glycogenolysis, gluconeogenesis, and ketogenesis. All these three lead to increased ketone and glucose production, ultimately leading to increased ketone and glucose in the bloodstream. The symptoms of diabetic ketoacidosis are nausea, vomiting, thirst or polyuria, abdominal pain, shortness of breath. The physical findings are tachycardia, dehydration or hypotension, tachypnea, that is Kussmaul respiration, respiratory distress. There can be fruity odor in the breath of the patient, abdominal tenderness, lethargy, obtundation, cerebral edema, and possibly coma. Coming to the etiology, the patient must be diabetic. There can be infection. Insulin administration is inadequate. Cerebral coronary mesenteric or peripheral infarction. Certain drugs like cocaine or pregnancy. Now coming to pathophysiology, when there is insulin deficiency, there is decreased glucose uptake. in the body. So when there is decreased glucose uptake, there is a case of hyperglycemia, or more amount of glucose will be present in the bloodstream. So when there is more glucose in the bloodstream, it will lead to osmotic diuresis. That is, more urine will be there, leading to dehydration. Also, insulin deficiency can lead to proteolysis, that is breakdown of proteins. The proteins are ultimately broken down into amino acids. So there is increase in amino acid concentration in the body. So increased amino acid concentration ultimately leads to gluconeogenesis and glycogenolysis, ultimately leading to formation of more glucose in the blood. Insulin deficiency also leads to lipolysis, that is fat breakdown. Fat breakdown can lead to increase in glycerol production in the body and free fatty acid release into the bloodstream. These free fatty acids lead to ketogenesis, ultimately leading to a state of acidosis in the body. So this is the pathophysiology of diabetic ketoacidosis. It arises because of lack of insulin in the body. The lack of insulin and the corresponding elevation of glucagon leads to increased release of glucose by the liver, a process that is normally suppressed by insulin. So there is release of glucose by liver from glycogen via glycogenolysis and also through gluconeogenesis. So this high glucose level spill over into the urine, taking water and solutes such as sodium and potassium along with it, leading to osmotic diuresis. So important electrolytes in our body such as sodium and potassium are also released out of the body through urine. This leads to polyuria, dehydration, compensatory thirst and polydipsia. The absence of insulin also leads to the release of free fatty acids from adipose tissue, leading to lipolysis, which are converted through a process called beta oxidation of fatty acids in the liver into ketone bodies. Ketone bodies are acetoacetate and beta hydroxybutyrate. The ketone bodies, however, they have a low pKa value and therefore they turn the blood acidic. So this condition is known as metabolic acidosis. So initially the body buffers the change using bicarbonate buffering system, but this system is quickly overwhelmed due to a huge production of acid in the body, and other mechanism must work to compensate for the acidosis. So one such mechanism is hyperventilation. It is a body's defense system to lower the blood carbon dioxide level. So this is a form of compensatory respiratory alkalosis. So initial evaluation will be to identify the precipitating events leading to elevated glucose such as pregnancy, infection, omission of insulin, myocardial infarction, central nervous system event, etc. Assess the hemodynamic status of the patient, examine for presence of infection, assess the volume status and degree of dehydration, assess presence of ketonemia and acid-base disturbance. So what lab investigations you have to send? Send serum blood glucose level, serum electrolyte levels, bicarbonate levels, amylase lipase levels, urine dipstick test, ketone level, then serum or capillary beta hydroxybutyrate level, ABG measurement. ABG is very important to rule out acidosis. Then send CBC or complete blood count, burn and creatinine levels or blood urea nitrogen level, urine and blood culture if we suspect any infection, and ECG. The imaging tests that are done are chest radiography to rule out pulmonary infections such as pneumonia, head CT scanning to detect early cerebral edema, Use low threshold in children with diabetic ketoacidosis and in patients with altered mental status. MRI can also be done of the brain to detect early cerebral edema if there is altered consciousness in the patient. Now coming to the management of diabetic ketoacidosis, the initial hospital management includes replacement of fluid and electrolytes to treat dehydration first. Then IV insulin therapy, watch for complications and treat the underlying cause. So once the issue is resolved, convert to home insulin regimen and prevent recurrence in the future. So this chart depicts the protocol for management of adult patients with diabetic ketoacidosis. So once you are done with your initial evaluation and you are quite sure about your provisional diagnosis, start with IV fluid replacement. So determine the hydration status of the patient first. If the patient is in hypovolemic shock, then administer 0.9% of NaCl. If there is mild hypotension, then look for the serum sodium level. If the sodium level is high or it is normal, then administer 0.45% of NaCl and check the sodium status again till it reaches 250 mg per dl. Till the glucose level reaches 250 mg per dl. And if the sodium is low, then give isotonic 0.9% NaCl and again check the glucose status. Then go ahead with insulin administration. Now insulin can be administered in both IV route and subcutaneous or IM route. Next, go ahead with potassium correction using potassium chloride injection if potassium concentration is less than 3.3. And if potassium is more than 5, then do not give potassium supplementation. Rather, check for potassium every 2 hourly. Then the last but not the least is assess the need for bicarbonate. If the pH is less than 6.9, then sodium bicarbonate injection should be given. It should be diluted in water, infused at a rate of 200 ml per hour. And if the pH is more than 7, there is no need to administer sodium bicarb. Whereas if the pH is around 6.9 to 7, then sodium bicarb should be diluted in 200 ml of distilled water and infused at around 200 ml per hour. Then repeat the bicarbonate level and check its level. If the level is normal, then you can stop your procedure. So these are the protocols for management of adult patients with diabetic ketoacidosis. Coming to complications of diabetic ketoacidosis, the complications are shock. Shock can arise if it is not improving, if the condition is not improving with fluids. It can lead to vascular thrombosis because of severe dehydration, cerebral vessel obstruction. There can be pulmonary edema because of aggressive fluid resuscitation. There can also be cerebral edema which can arise in the first 24 hours. There will be alteration of mental status of the patient and the patient may require intubation with hyperventilation. So these are the strategies for preventing diabetic ketoacidosis as per American Family Physician, volume 71. The patient should be educated, blood glucose monitoring should be done, sick day management, home monitoring of ketones or beta hydroxybutyrate, supplemental short-acting insulin regimens should be followed, easily digestible liquid diets when the patient is sick, reducing rather than eliminating insulin when the patients are not eating, guidelines for when patients should seek medical attention, case monitoring of high-risk patients, and special education for patients on pump management.